Thank you for the kind presentation, and thank you to the organizer to invite me for this very interesting meeting. My topic is not a new topic because the association between renal stone and renal failure dates back to more than 1 century ago. At the beginning, were presented anecdotal cases, but in the last 50 years, there are a lot of studies confirming this finding. The first robust statistic study was the study of the National Institute of Health that proved increased the risk of chronic kidney disease in patients with an history of renal stones, about 0.9% of risk. And a subsequent study with more patients involved confirmed this finding and also focused on the risk of end-stage renal disease, demonstrating that both the creatinine tended to increase a long time in patients with an history of renal stone, but also the risk of dialytic treatment and kidney transplant was higher. You see the two lines that divide a long time. A lot of other studies were published. The meta-analysis confirmed the finding of the National Institute of Health with proving a risk of 1.46%, 46 risk higher of 1.46. Another study from the Mayo Clinic confirmed the risk of dialytic treatment and kidney transplantation. You see the risk in renal stone former in a follow-up of 12 years is 0.93, and the non-renal stone former only of 0.36. Why? There are many possible explanations of renal damages. Some hypotheses were just proposed before from my co-speakers that illustrated a lot of things that I have to say to you. But basically, we have obstruction with infection that sometimes is secondary, crystal deposition, comorbidity, and treatment for remove the stone. We have not to forgive that. Abstraction. We know by study of the last century of the 60s that when you when you ligate the ureter for more than 24 hours in a rat model, you have a loss of about 15% of nephrons. That is irreversible. And this is related to a loop, to a normal intrarenal loop that after a forced reply of vasodilatation induce vasoconstriction, and this vasoconstriction cause a prolonged ischemia that evolve after that in inflammation with glomerulosclerosis, tubular atrophy, and interstitial fibrosis. Really, in our patient, we have not the complete closure of the ureter, so the model the clinical model is a little bit different because we have incomplete obstruction and sometimes intermittent obstruction. So the time that need to have a renal damage is not well defined because there is not a single model, but basically, if you prolong obstruction for more than 1 month, you risk to have a loss of functional nephrons. And this, in the first period, is compensated by hyperfiltration of the surviving nephrons, but in the long time, surviving nephrons cannot sustain this overwork, and renal failure demonstrate after in the long time. infection is often associated to obstruction and can be by itself a cause of renal damage. Most of what I have to say to you about crystal deposition has been illustrated before. Basically, what is important to highlight is that crystal deposition did not happen in all the renal stone formats. There should be conditions that promote the crystal deposition, and basically it is a high level of supersaturation, because in that condition you have prevalent formation of plug in the Bellini duct. There are two mechanisms, the plaque on the papilla, and the other mechanism is the formation of plug in the Bellini duct. And in that case, you reproduce in miniature the event of obstruction in the urinary tract, because you have obstruction, and this obstruction causes an inflammatory response, and this inflammatory response is that involve the formation of calcification and nephrocalcinosis locally. So we have to look to hereditary stone disease. This was nicely demonstrated before. We must remember, what we have to remember is the importance to have obstruction of the Bellini duct. And we have many diseases as the hereditary hypercalciuria, such as Dent disease, primary hyperoxalurias, that can form crystal deposition in all the body, not only in the kidney. And you see in the kidney, all the kidney without contrast is well delineated by the crystals. And then we have the deficiency of adenosine phosphoribosyltransferase transferase. You see that crystal form in the tubule. You see they are slight yellow in the tubule. They are birefringent and under polarized light microscopy. The hydroxyadenine is insoluble, relatively insoluble. This causes end-stage renal disease. Cystinuria, that is the most common hereditary disease, really is not really so rare, because it's the second more common recessive autosomic disorder in all type of recessive autosomic disorder, not only in the kidney. And it is 1 out of 7,000 newborns, so it's not so rare. In many cases, patients did not form stones, and you do the diagnosis looking to the relatives of the affected patients. Cystinuria in all the hereditary disease is that promote less crystal deposition, because it's very rare to find nephrocalcinosis, or probably I never seen one, but I say it's very rare to have crystal deposition of cystine in the kidney, because as Professor Stomatoia demonstrated, sometimes crystal form free in the callus. This is strange, but probably came from plug that move to the callus. Another type of stone that are associated with the risk of chronic kidney diseases are bruchite stone. Bruchite stone are only 5% of all calcium stone and about 20% of all calcium phosphate stone. And they present with frequent plugging of Bellini ducts. That you see is the point on the right. And these make frequent association with tubular damage. Bruchite stone are not hereditary stone. Why they form instead of hydroxyapatite is not so well known. but we know that they are associated with hypercalciuria in almost all cases, and that they are very resistant to treatment, to endoscopic and extracorporeal treatment. Surgical treatment. The last topic is the surgical treatment. I want to remember that some years ago, we presented the study, 40 years ago, about the tubular damage after renal stone procedure for stone removal. At the time, open surgery was still done, and you can see that the extraction of renal enzyme of necrosis is quite high after open surgery, especially if the pedicle was clamped. At the time, it was done for big staghorn stones. But what we did not expect was that also shockwave lithotripsy caused a little bit damage, a little bit tubular damage. And was more surprising is that it was more than percutaneous nephrolithotomy. It was confirmed that the damage is associated with the number of shocks and the type of lithotripter, and after that it was demonstrated that probably the cause of this transient damage is the vasoconstriction that results from exposition of the kidney to shock waves. But subsequent study were not able to demonstrate with different method any significant effect on renal function a long time. So we have a bioeffect that is measurable and present, but it did not cause damage, alteration of glomerular filtration in the time. And we also checked patients with solitary kidney that were exposed to shockwave lithotripsy, and we were not able to demonstrate any relevant damage. The new methods, especially retrograde intrarenal surgery, are associated with a risk a little risk of renal tubular damage. Again, is transient and is related to the amount of irrigation. Comparison between PCNL and retrograde intrarenal surgery are in favor of retrograde intrarenal surgery, and also comparison of shockwave lithotripsy and renal retrograde intrarenal surgery were compared in favor of retrograde intrarenal surgery. That basically is the less invasive treatment. But so we have to conclude that there are bioeffects that can be detected and measured for all type of treatment, but no demonstration of long-term effects on renal function and blood pressure. But we have to remember that repeated treatment should be avoided as much as possible, because in any case, we are speaking of treatment that have no complication, but some treatment have complication. And that individual patient who had complication is a patient with a risk of renal failure. So the limitation of the treatment is crucial. And to finish, we have to remember that new technology are changing things, because we have new problems. We have the problem of high temperature. We have the problem of high pressure in the renal cavities. And we have not, at the moment, definite evidence that this can be sustained by the kidney, and we need to have guidelines to define which treatment is not associated with a risk of renal damage. To finish, I want to invite all of you to the 15th International Symposium on Urolithiasis that will be held 2026 in Chicago.
Thank you very much.